Have you ever had a physical injury, maybe a nagging shoulder pain that just, well, it just wouldn't go away no matter how perfectly you did your physical therapy exercises?
Oh, yeah. It is incredibly common. More than most people realize, honestly.
Right. I mean, you show up to the clinic, you do the stretches, you pull the resistance bands, you ice it, you heat it, you follow the protocol to the letter.
Exactly. You do everything right.
And yet, like 2 months later, you are still wincing when you reach for a coffee mug. It's so frustrating.
It really is. And the statistics on this are actually kind of staggering,
Yeah, if you go to physical therapy for a common shoulder injury, there's basically a 50% chance you will not get better.
which is, I mean, that's essentially a coin toss.
Right. Half the people who walk into a clinic either don't heal or they heal and immediately relapse. So today we are doing a deep dive into why that happens.
And the answer might actually surprise you.
It totally blew my mind. We are looking at a fascinating study published in the Journal of Orthopedic and Sports Physical Therapy from 2026.
Yes, by Courtney Mears and a really expert team from USC, UC San Diego, and the University of Florida.
And the main mission of our deep dive today is to explore this hidden link between what is going on in your mind and how your shoulder actually physically heals.
Because the deciding factor between healing and, a chronic lifelong burden, it might not be in your joint at all.
Yeah, it might actually be a literal software glitch running in your mind.
I love that analogy. It completely upends the traditional mechanical view of physical rehabilitation.
Okay, let's unpack this, because to really get what this study did, we need a visual.
Right, so the visual backdrop I have in mind today isn't just your standard skeleton.
No, it's way more complex than that.
Exactly. Imagine a highly detailed, brightly lit anatomical map of the human nervous system. So glowing, branching pathways of nerves, synapses, brain centers.
Like a glowing electrical grid.
Yes, and that grid is intersecting directly with the biomechanics of a human shoulder joint, because that intersection is the exact focus of this prospective longitudinal observational study.
Right. They followed 64 people with something called rotator cuff tendinopathy, and they followed them through a standard 8-week resistance exercise program.
But here is the kicker. Instead of just measuring their physical strength or, how high they could lift their arms.
Which is what they usually do, right?
Right. Usually it's just about range of motion. But this team, they tracked their pain-related fear and their catastrophizing.
Which is so interesting. They wanted to see the unknown variable. But before we get to the fear, we need to understand the gap in traditional physical therapy. Like, what is the physical problem here?
So we're talking about the rotator cuff. It's one of the most common causes of musculoskeletal shoulder pain.
And what exactly is happening in a shoulder with rotator cuff tendinopathy? Why does the standard treatment fail half the time?
Well, the standard treatment is resistance exercise. You load the tendon to make it stronger.
Right, you break it down to build it up.
Exactly. But it doesn't work for everyone. If you imagine a healthy tendon as a tightly woven bundle of strong nylon ropes.
Okay, nylon ropes. Got it.
A tendinopathic tendon looks more like a frayed, disorganized bowl of spaghetti under a microscope. The fibers are all misaligned.
Oh, wow. Okay, so doing resistance exercises is supposed to force that spaghetti to straighten out into a rope again.
That's the mechanical theory. Yeah, it makes perfect biomechanical sense.
But if 50% of people aren't getting better, there has to be a missing link. It's like taking your car to the mechanic for a transmission issue, right?
Right.
The mechanic can replace the gears, flush the fluid, rebuild the hardware. But if the real problem is a software glitch in the car's computer,
So the car's still going to stall when you drive it off the lot. The hardware is fixed, but the software is overriding it.
exactly. So here, the software glitch is the comorbid psychological factors, the threat of pain.
Yes. And the researchers break down this core concept right in the introduction. Psychological factors related to an exaggerated threat of pain and fear of movement can actually adversely impact the pain experience itself.
I mean, that makes sense. If you're terrified, your body reacts.
It leads to suboptimal outcomes. Your muscles tense up to guard the joint, which actually increases compression on that irritated tendon.
So your fear literally makes the physical environment of the shoulder worse.
Exactly. And it sensitizes the central nervous system, too. It basically turns up the volume on the physical pain.
So we know baseline fear can predict bad outcomes. If you walk in terrified on day one, you're going to have a bad time.
Right, that's an established fact.
But the driving question here is, does that fear change while you do physical therapy? And is that change different from person to person?
That is the exact unknown gap this study aimed to fill. Because even if average fear levels are relatively low in this group, they might still fluctuate over those 8 weeks.
And those fluctuations could alter the clinical outcomes.
Precisely. They wanted a real-time monitor of the mind over an episode of care.
Okay, so you might be wondering how scientists actually measure something as objective as fear of movement. I mean, it's not like measuring blood pressure.
No, it's much trickier. So this leads us to this study's specific methodology and their toolbox.
Let's talk about the people first, the demographics. There were 64 participants, right?
Yes, 64 individuals. But they had a very strict age inclusion criteria. They were strictly aged 18 to 55.
I noticed that in Table 1, and that seems young for a shoulder study. Why exclude older adults?
Well, they had to exclude older adults due to the likelihood of full-thickness tendon tears.
Oh, so literally the tendon ripping completely off the bone?
Exactly.
Yeah.
As we age, natural tissue degeneration makes those catastrophic mechanical failures much more common.
So by capping the age at 55, they made sure everyone actually had tendinopathy, that frayed spaghetti, and not a completely ruptured hardware system.
Right. They needed a sample where the physical hardware was intact enough to actually respond to the exercise protocol.
That makes total sense. And looking at the rest of the demographics, it was mostly white, about 54%, around 60% male.
And their baseline Pennsylvania shoulder score, the Penn score, was under 90 out of 100.
And just for context, a 100 is a flawless, perfect shoulder. So a baseline under 90, mostly around 72, means these people are hurting.
Yeah, they have real measurable disability in their daily lives.
Okay, so how did they measure the software, the psychological state?
They use a tool called the Optimal Screening for Prediction of Referral and Outcome Yellow Flag, or the OSPROYF.
That is a mouthful.
It is, but they specifically focused on the fear avoidance domain of this tool.
And they broke this down into 4 specific factors, right? Let's go through them because this is where it gets really interesting.
Sure. The first one is the FABQPA. That stands for Fear Avoidance Beliefs Regarding Physical Activity.
So that's just the basic fear that moving around like walking or carrying a grocery bag is going to damage the shoulder.
Exactly. And then the second one is the FABQW, which is Fear Avoidance Beliefs Regarding Work.
Which feels totally different, because if I hurt my shoulder playing pickleball, I'm bummed. But if I'm a construction worker and I think moving my shoulder is going to destroy it,
Then your livelihood is threatened.
right, the fear of not being able to work has to be a massive layer of existential stress.
Oh, absolutely. The anxiety profile for work is intensely elevated.
Okay, the third factor, the PCS, the pain catastrophizing scale. I have to push back on this word a bit.
Oh, why is that?
Well, catastrophizing sounds like such a dramatic word. Like, if a doctor tells you you're catastrophizing, it sounds like they're calling you a drama queen. What does it actually mean clinically?
That's a really important point. Clinically, it's not a judgment at all. It just describes a cognitive coping style. It basically means fixating on the worst possible outcome of the pain.
So it's not them making it up, it's just their brain running away with the worst case scenario.
Exactly. It's a mix of rumination, magnification, and helplessness. They feel a twinge and immediately think, I'm going to need surgery and my life is ruined.
Wow, okay, that makes sense. And the fourth one is the TSK-11, the Tampa Scale of Kinesiophobia.
Yes, kinesiophobia.
I just love that word, kinesiophobia. It's the literal fear of movement itself.
The belief that the body is fragile and any movement is dangerous. Yes.
Okay, so we have the 4 fear measures, but how did they decide if the physical therapy actually worked at the end of the 8 weeks?
For that, they use the PASS test. It defines patient satisfaction.
The patient acceptable symptom state. How does that work?
There's a very straightforward question asked at 8 weeks. They ask, if you had to stay in your current state for the next few months, would you be satisfied?
I love that because this isn't just asking if you feel a little better, like going from a D- to a D+.
Right. It's not about a minor clinical improvement on paper.
Yeah, the PASS asks if you are actually satisfied. It's the difference between feeling better and feeling your best. You either say yes or you say no.
Exactly. It makes the patient the ultimate authority on their own recovery.
Okay, so now that we know how they measured everything, what actually happened to their fear levels over the 8 weeks of doing these exercises, let's look at AIM-1, the overall trajectory.
Well, the first major finding was pretty optimistic. On average, across all 64 participants, pain-related fear and catastrophizing significantly decreased over time.
Across all 4 of those measures, the FABQ, the PCS, all of them.
Yes. The group average dropped across all 4 measures.
Okay, so what does this all mean? I have a theory.
Let's hear it.
I think just doing the resistance exercises, day after day, and realizing your shoulder doesn't actually fall off, it probably builds confidence. It's like accidental exposure therapy.
I completely agree. That's a great way to put it. Exposure to the movement helps dismantle the exaggerated threat of pain. The brain learns the movement is safe.
Okay, and there's always but with group averages,
Yeah.
when you look at figure 1 in the study, it tells a very different story.
Ah, yes. Figure 1, the messy reality.
If the visual backdrop shifts to figure 1, it's just chaotic. It's these colorful line graphs.
It looks like a tangle of neon spaghetti. Well, the thick black trend line representing the group average went down nicely.
The thin, colorful lines representing the individual participants went literally everywhere.
Some went straight down, some stayed flat, some spiked wildly.
Which just goes to show you averages lie. Your personal experience of pain recovery is highly variable.
It really highlights why a one-size-fits-all physical therapy protocol is destined to fail so many people.
Absolutely. Because the individual trajectories were so messy, the researchers had to split the group in two using that PASS test. And this brings us to AIM 2.
The tale of two shoulders. Responders versus non-responders.
Right. And here's where it gets really interesting, because this is where the data gets wild.
So they took the 64 people and split them based on who was satisfied at 8 weeks.
Okay, what was the split?
47 people answered yes.
Yeah.
They were the responders. And 17 people answered no. They were the non-responders.
And when you look at the diverging paths of fear between those two groups, it's a stark contrast.
It really is night and day. While the satisfied group saw their fear drop significantly,
the unsatisfied group actually had higher levels of pain-related fear at the end of the program.
yes. Let's look at the specific numbers for the non-responders because they are crucial. Over the 8 weeks, their fear of work, that FABQW scale, actually increased by a mean of 0.9 points.
It went up.
It went up, and their kinesiophobia, the TSK-11, increased by a full 1.0 point.
Wait a second. You're telling me that for 17 people, doing evidence-based physical therapy exercises actually left them with more fear of movement and work than when they started?
That is exactly what the data shows. Meanwhile, the responders dropped 3.3 and 2.5 points, respectively, on those same scales.
That is mind-blowing. The intervention made them more scared.
What's fascinating here is that physical therapy, without psychological awareness, might not just be ineffective for some patients.
It might actively coincide with a worsening mental state regarding their injury.
Exactly. Because if you force a brain that is terrified of movement to do the movement, and the pain doesn't get better.
The brain says, see, I told you movement was dangerous, you're hurting me. Confirmation bias.
Precisely. The therapy itself proved their catastrophizing correct. Their mind.
Okay, so we've established that fear changes differently for different people. AIM 3 is the mind-body correlation. How exactly does this psychological trajectory map onto the actual physical healing of the shoulder?
For this, the researchers used mixed effects models. They compared the trajectory of the fear factors with the trajectory of the Penn shoulder score.
Which is that score out of 100, right? Where higher scores in Table 2 indicated improvement and reduced disability, moving from around 72 up to maybe 88.
Correct. And for the responders, they found a lockstep link. Less fear equaled less disability.
So the participants who had a decrease in their pain-related fear also had the greatest improvements in physical shoulder function.
Yes. The mind unburdened itself, and the physical tissue demonstrated immense functional recovery.
But then you have the non-responder trap.
Yes, those 17 individuals. Not only did their fear not improve, but the statistical models showed absolutely no significant relationship between their minimal changes in fear and their changes in disability.
It's like their mind and their shoulder were completely stuck in a negative feedback loop. The software glitch was preventing the hardware from rebooting.
That is a perfect way to conceptualize it. When catastrophizing stays elevated, the nervous system stays locked in a state of high sensitization.
So the brain is just screaming at the shoulder.
Exactly. And chronic stress triggers cortisol release, which actively impairs tissue healing. It even alters motor recruitment patterns.
Meaning they tense up their traps, shrug their shoulders, and don't even use the tendon properly because they're so scared.
They subconsciously sabotage the biomechanical treatment.
That is incredible. And it brings us to Section 6, the clinical implications, because this isn't just an interesting psychological quirk.
No, it fundamentally changes how physical therapy should be administered in a clinic.
Right. Treat the brain to fix the joint. And the study highlighted a really specific time frame for clinicians to catch this, didn't they?
They did. They pointed to a critical 2 to 4 week window.
Okay, so a patient comes in, they've been doing the bands for 3 weeks. What is the physical therapist looking for?
If a patient with rotator cuff tendinopathy isn't showing meaningful physical improvement in that first 2 to 4 weeks,
Right, the PIN score isn't moving.
and they simultaneously have high fear or catastrophizing, they are likely on the path to being a non-responder at week 8.
The yellow flags are waving. So what do? Tell them to stop being scared. Hey, just calm down.
Telling a patient to calm down is probably the worst thing you can do. It just invalidates their experience.
Right, it spikes their anxiety more because they feel ignored. So what is the actual intervention?
The clinician needs to pivot to psychologically informed interventions. This might mean temporarily pausing the heavy resistance bands because the load is too threatening.
And starting what?
Starting pain neuroscience education? Or P&E?
Pain neuroscience education. Teaching the patient that hurt does not always equal physical harm.
Exactly. It's an empathetic dialogue. You explain that the nerves in their shoulder are like an overly sensitive car alarm.
The alarm is going off when a breeze blows, not when someone is breaking the window.
Right. And you teach them that doing the exercises isn't ripping the tissue more, it's signaling the body to build stronger tissue.
That is so vital because I read a qualitative note in the study that really stuck with me. The fear these patients have, it usually stems from a very logical place.
Yes, they are worried about movement safety.
If you have a frayed rope and someone tells you to pull it, you logically fear it will snap. Acknowledging that fear of tissue damage is the first step to overcoming it.
Validating the logical root of their fear drops the threat value.
Mm.
And if necessary, the physical therapist might even refer them to a psychological professional.
Treat the whole human. Okay, before we declare this the ultimate unified theory of shoulder pain, we have to look closely at the study's blind spots and limitations.
As any good scientist would.
Right. First up, demographic limitations. We talked about that age cap of 55. Because they capped it to avoid full-thickness tears, we really don't know how this applies to older adults.
We don't. The fear profile of a 70-year-old is likely very different from a 30-year-old.
Yeah, a 30-year-old fears losing their construction job. A 70-year-old fears losing their independence. Totally different software glitches.
Exactly. I'd also add that the sample was largely white, which definitely affects generalizability to a more diverse, broader population.
Different cultures process and express pain very differently, so that's a big blind spot. What about the test itself, the PASS test?
Well, the PASS test is a simple yes or no, and that is a significant statistical limitation.
Because human satisfaction isn't binary. Think about a really competitive recreational tennis player.
Right.
They might have vastly improved their shoulder. Their pain at rest is gone. But if they still can't pitch a 90-mile-per-hour fastball or serve at top speed...
They might answer no to the PASS test simply because their high expectations aren't met.
Exactly. Throwing them into the non-responder category and completely skewing the data, even though they physically healed a ton.
The dichotomous nature fails to capture the nuance of massive but incomplete improvement.
And there's one more massive caveat here, the classic scientific disclaimer.
Correlation versus causation.
Right. This was an observational study. We cannot say the resistance exercise directly caused the drop in fear.
We only know they occurred together. The fear might have dropped naturally over time or because the physical therapist was just a really nice, comforting person.
To prove causation, you'd need a randomized controlled trial.
Exactly.
But even with those limitations, the takeaway here is just incredible.
Yeah.
To summarize this deep dive for you, your brain and your shoulder are intimately connected.
They're deeply integrated ecosystems.
Over an 8-week exercise program, the people who successfully healed their physical shoulder pain were also the ones who shed their fear of movement.
They updated their software, which allowed the hardware to heal.
And those who stayed scared, stayed injured. The unaddressed fear actively sabotaged their physiological recovery.
It is a profound demonstration of the biopsychosocial nature of health.
It really is, and it leaves me with a final, lingering question to ponder on your own.
Oh, what's that?
Well, if our deepest, perhaps unconscious fears about pain and safety can literally predict whether a physical shoulder injury heals or becomes a chronic disability,
Yeah.
what other areas of our physical health or even our daily physical performance are secretly being held hostage by the software running in our minds?
That is a fascinating thought.
Yeah.
Are our immune systems or our digestion being throttled by panicked software.
Exactly. It makes you question everything. Thank you so much for joining us on this deep dive into the source material.
Keep questioning the connections between the mind and the body.
And we will catch you next time. Keep moving safely.